We shall now go on to our next speaker, who's another trailblazer from Kolkata, an innovator par excellence and could rise to any challenge in cataract surgery. Dr.Suven Bhattacharjee, you could share your screen. He is going to be dealing with management strategies in PXF and in small pupils.
Please unmute yourself, Dr. Suven.
I'll do that. Yeah, thank you. Yeah, so thank you, Dr. Chitra, and thank you, Academic Research Committee, for this opportunity. So I'll be speaking on management strategies in pseudoexfoliation and small pupil. So I'll be mainly talking about non-dilating pupils and intraoperative meiosis. So I'll be concentrating mostly on management. I do have a financial interest of the VX Pupil Expander. I'll try to keep that to the minimum. And I do acknowledge the contribution of Dr. Neta Rosatelli and Dr. Deepak Megur, whose videos I've used over here. Now, pseudoexfoliation is a typical fibrillary white flaky material from the lens, which deposits on the lens capsule, ciliary body, zonules, corneal endothelium, iris, and pupillary margin. What's more important is it's associated with comorbidities with a small and non-dilating pupil, open-angle glaucoma in 50%, and a subluxury cataract. There is a high incidence in Scandinavian countries. Now, Chang and Campbell in 2005 described this wonderful condition called IFIS, which kind of gave us something to understand. What is important over here is that he stated that unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. That means it's an elastic pupil. So we come to the important question is in the OPD or OT, what is the safe preoperative pupil size to eliminate risk of IFIS? Now, there could be any guess from 5 millimeter, 3 millimeter, 7 millimeter. Now, this is a paper published in 2011 by Alessandro Casicchio and co-workers. And the conclusion was that for a pupil 7 millimeter or smaller, the risk of IFIS existed regardless of alpha adrenergic receptor antagonist treatment. So that's 7 millimeters. Now, IFIS could be caused by a whole lot of predisposing conditions. There are a huge list of drugs. And more importantly, systemic conditions. Hypertension is a risk factor. And as we know, practically every alternate patient has hypertension. So no amount of history taking could be absolutely foolproof. Now, for those who think that in India, the problem isn't too much, well, this was a huge study by Shilpa Goel and co-workers, which suggested that prevalence of tamsulosin intake and IFIS incidence is higher in India compared to the global incidence. And current tamsulosin and alfazosin intake and hypertension are important risk factors. So remember, hypertension is a very important risk factor. So if you look at the key differentiating features, now we have a group which is senile meiosis, uveitis, glaucoma, and then we have pseudoexfoliation. Now they share a common problem is that they have a non-elastic rigid pupil. And then we have the IFIS, which is an elastic pupil. There is progressive meiosis and erythroid. We do have areas of overlap in between all the three, which they will have subsets over there, but that is grossly how you differentiate. Now, in the elastic pupil, it's like a rubber band. You can use any pupil expander that will work, whereas non-elastic pupil is more like a fibrous ring. It's like a string. You cannot stretch it. You can only tear it. So you need a strong and bulky expander or device to tear it. Now, when we come to the management, I divide it into two parts. Part one would be preparation, where we talk of preoperative NSAIDs, and we must consider the fact that every eye is a potential IFIS candidate. The preparation is in the mind. Let's give our ego a break. Whether we can do a phaco through a 4 millimeter or 5 millimeter pupil is not important. If it's your own eye, you would like the surgeon to be safe rather than sorry later. We need to release posterior synechia and peripupillary membranes completely. Intracameral injection of combination mydriatics and local anesthetics, that's a very good choice. If it works, very good. There are a lot of sugarcane, epi-sugarcane, and various things which you can find in literature. I'll give you some references in the end. And we need to, most importantly, test and distinguish the elastic from the non-elastic rigid pupil. So when we come to the implementation part of the management, once we have decided whether the pupil is elastic or non-elastic, we decide whether you want to use OVD alone, or iris hooks, or a pupil expander. So if you use OVD, it's a viscometric and a high molecular weight viscoelastic, Helon 5. If you're good at it and you can control with a low flow rate, then it's good. Or else we'll come to the iris hook tips and the pupil expander tips. And remember, there are certain post-op medications that we need to take care of. So preoperative non-steroidal anti-inflammatory drugs. Now, they inhibit surgically induced meiosis due to iris manipulation and prostaglandin release. They do not have a primary role in pupil dilatation. We must remember that. They just inhibit the prostaglandin release. So when we come to mechanical dilatation of pupil, now pupil stretching, like I said, will not be effective in an elastic pupil, that is an IFIS pupil, whereas controlled stretching will be helpful before we use an expander in a rigid fibrotic pupil. So we have a group of iris hooks or retractors, which is one group, which is very commonly used, and we must all know about it because that's something which we fall back time on again. And then we have the Mulligan ring and the BX pupil expander and the I-ring and other devices. So this is a little bit of a video about IFIS. Now, this is a pre-2005 videos when we did not even know what is IFIS. So look at that pupillary margin and look at that billowing of the iris and the fluttering of the pupil margin. That's so typical of IFIS. Now, this is a myopic eye, and I'm sorry of the video quality because there's a pretty old video, some of them taken from VHS. You might not have seen a VHS cassette also. So now that's very typical. You inflate the anterior chamber and the pupil becomes large, and again, it comes back on you. So now this is a case where I'm trying to show is despite iris hooks, we are having iris prolapse. So there is no device which is absolutely foolproof and guarantees no iris prolapse. What iris hooks and pupil expanders do is they ensure adequate pupil size for safe emulsification. That's what it's doing over here. So the iris is frayed, the knuckle of iris is prolapsing, but we can go ahead and do that phacosurgery. And you can see that patulous iris, it's like a sail of a boat, and as you inject viscoelastic, and we need to protect the iris as we inject the IOL and the nozzle of the cartridge goes in. So that is iris hooks. And what I want to show is whatever device is used. Now here's a BX pupil expander being used for IFIS, and this was a toric IOL, a shallow AC, and we just had a slight hint of IFIS, and when we used the BX pupil expander, we did manage to get a good dilatation, but then iris did prolapse. So it's the nature of the iris, the extent of the IFIS that is there. It's a severe IFIS, the iris is going to prolapse irrespective of what device you use. You may try a lot of low flow techniques and other things. Having a device which can come out through the side port is advantageous when you're having iris prolapse. So when we come to the medical management of IFIS, like I said, history taking cannot be foolproof. IFIS can occur in patients with pre-op pupils of 7 millimeters also, even without history of ever taking an alpha blocker. IFIS can occur more than 1 year after tamsulosin has been discontinued. IFIS can occur within 3 to 7 days of initiating tamsulosin, and stopping tamsulosin is really of no value, and in fact, it may cause painful urinary retention. And we must remember that often women are put on tamsulosin for urinary tract infection. A little about pupil expansion devices in IFIS. This is something I've come to understand over a period of time. If you look at meiosis and iris prolapse, iris hooks or pupil expanders, what they do is provide us a constant pupil size and good visibility for safe phacoemulsification. Whereas iris prolapse, no device helps. Iris prolapse depends on IFIS severity and the pathological damage to the iris due to stroma and muscles. So there is no credit to the pupil device when you don't have iris prolapse. It's just lower grade IFIS. So a favorable pupil expansion device would be one which requires small incisions, there's less leak and less iris prolapse, which is thin and has a low vertical profile. It allows more space in the anterior chamber for manipulation, and it can exist through a side post when iris may be prolapsing. So the choice of pupil expander will depend on how you wish to tear the rigid or non-elastic pupil. Like I said, an elastic pupil, everything works. So if you could do it with 2 Kuglen hooks, you could use something as thin as the BX, which is not a very strong device because it's hair thin, 75 microns. If you want to tear it with a pupil expander, you'd have to use a Mulligan ring or an APX or an I-ring, which is a bulky device. And the downside is that it occupies more space in the anterior chamber. Now, if you're having a subluxated cataract, Dr. Chitra showed wonderful cases of subluxated cataract. There, I don't think a pupil ring is of much value. It is wiser to go in with iris hooks, which can asymmetrically expand the pupil in clock hours of interest. So you might like to relax the iris hooks in the non-subluxated areas and probably tighten it up in the subluxated area to give better visibility. If you're having intraoperative meiosis, iris hooks is a good choice always. And BX pupil expander would probably be the next choice because it can very safely negotiate under the pupil margin without engaging the capsulorhexis margin. The Mulligan ring is a little bit dicey over there. It can catch the capsulorhexis margin and lead to capsulorhexis tear. So we need to check the elasticity or rigidity of the pupil before starting. This is how we do it. Just inject BSS through the side port, and if that pupil expands momentarily, that means that the pupil is expansile. It can be expanded. Now, let's see another example of the non-stretchable. Let's see, here inject BSS and the pupil really doesn't budge much. So this is a rigid or fibrous pupil. So we can stretch it with by manually using 2 Kuglen hooks. And now we render it slightly stretchable to about 4.5 millimeters. And then it's very easy to use any device with the iris hooks, pupil expanders, rings, whatever you want to use. It's important to understand how we inject viscoelastic and where we inject viscoelastic, irrespective of what we use, iris hooks or pupil expanders. So when you inject viscoelastic in the anterior chamber and overdo it, you tend to flatten the iris on the lens capsule. And that is not very favorable. Instead, if you inject viscoelastic at the pupil margin, under the pupil margin, to just lift off that pupil margin a little, that facilitates your placement of the device. That keep the anterior chamber underfilled with viscoelastic. Iris bowing will help in hooking the iris and tucking the flanges. Overfilling the AC pushes the iris against the lens capsule, it plasters it against it. Injecting viscoelastic under the pupil margin to create space for the iris hooks and flanges works very well. Now, this is how we remove the fibrotic and sweep that spatula under that iris so that you can remove some total posterior synechia, and then you have rendered that pupil elastic, and you can use any device. I'm sorry, most of my videos are BHEX, though Dr. Chitra asked me to refrain from using too much of BHEX, but most of my videos contain BHEX as an example. But you could use any device once you've rendered the pupil expandable by removing that fibrous ring. So now I'll show you a wonderful video where I'll show you that the pupil size really doesn't matter. Look at that pupil. I'm so sorry, it's not playing. Is it visible?
Yes, yes.
Yeah, okay. So once we have removed that fibrotic ring, see the size of the pupil. It's less than 1.5 millimeter, but look at it. It's an expandable pupil. You can stretch it. See, removing that fibrotic pupil, this Dr. Neto is a very skilled surgeon. So he removed that fibrotic ring so beautifully. And now with the bimanual technique, you don't really need to stretch this pupil bimanually. Here, it's rendered the pupil expandable. So you can use any device now. So it's not the size of the pupil, it's whether it's elastic or rigid is what matters. So how big do you want the pupil to be? Currently, I think any device that gives us an assured 5.5 millimeter pupil is good to do phaco. A 5 millimeter capsular access is good for all IOLs, and we are all skilled to perform phaco in a 5.5 millimeter pupil, which will not get smaller. If you have that assurance, we're good to go. This is stretching of a rigid pupil with pseudoexfoliation and a hard cataract by Dr. Deepak Magur. You can see that pseudoexfoliation which has got stained by the trypan blue. And once you have stretched it, that pupil has become not elastic, at least it's become stretchable. So you can use any device, a strong or a weak device really doesn't matter. And like I said, a 5.5 millimeter is good enough for even a hard cataract. So we don't need a very big pupil, which is what we tend to kind of overdo at times. If you have intraoperative miosis, look at the pupil coming down as the phaco is started. Now, this is the time when we should take a call and probably inject viscoelastic under that pupil margin over that capsular rim to create space for any device, whether you're using iris hooks or a pupil expander, and that gives you that safety margin so that you don't engage that capsular access margin. I'll be talking about a few iris hooks tips later as I show a video. So there you get a safe pupil size for phacoemulsification. Now, femtosecond laser-assisted cataract surgery, there is an element of meiosis which occurs. And in this paper in 2015, it was shown that the pupil area decreased by nearly 30%, and it was correlated with the duration of laser pretreatment, the laser capsulotomy to pupil margin distance, and the patient age. And the trigger was prostaglandin release into the aqueous humor at the time of capsulotomy. And this is a paper by Tim Schultz and co-workers. So let's look at a few iris hook tips. We do the side ports first, always. Do not overfill, as I said. Keep the anterior chamber slightly shallow. And then as we make those nicks, I like to place small marks. So clear corneal incisions, 0.5 millimeter, not more larger. And I like to place some marks. Retract the stopper far enough. Hold with the hook sideways Do not pull the hook all the way, just enough to give you retraction. And then we tend to overdo initially because we don't want to see the pupil as big as possible. So the capsular excess should be as per plan. Do not get carried away by the larger pupil that we have. While introducing any instrument, remember the pupil margin is anti-flex, so need to be careful so we don't engage the pupillary margin and damage it. The pupil has been elevated to the limbal plane. It's come more anteriorly. So while removing, just hold the stopper, advance that hook, turn it sideways, and just pull it, yank it a little bit. It straightens momentarily, and it just walks off. Look again, hold that stopper, push that pupil hook, iris hook, and then just pull it out, and it walks out. And this is the rhomboid pupil by Oetting and Omfroy. I'm sorry, this is a very old video. That is a subincisional iris hook. Now, when we look at this, this was a rigid pupil, and I did not really take care to do a symmetric stretch before. So I kind of asymmetrically pulled the entire pupil to one side, and look what happens as I do engage this hook. The pupil margin rips apart, and we have a bad tear. Now, this is a very useful tip. You just need to use a second instrument to tent that pupil margin, and you can engage that iris hook and not engage the pupil margin without engaging the capsular excess margin. You can very safely engage a capsular excess iris hook after a capsular excess. That's a very useful tip to use, at least in the initial days.
Thanks,
There's a little downside. Yep, I'll be finishing. So multiple corneal incisions, there's a risk of infection. There's a tendency for over-retraction. Remember that with iris hooks, these corner spaces are actually wasted spaces. We don't need the space, but we are stretching the pupil margin nevertheless. You could have cosmetic problems like marks and disfigured pupil. Now, there is an element of pseudophakic cystoid macular edema whenever you use a pupil device, whatever device you use, compared to when you do phaco in a well-dilated pupil, not compared to small pupil phaco. So there is an element of prostaglandin release, and there is CME, so it's better to use non-steroidal anti-inflammatory drugs in the post-op period to prevent any CME. So the take-home messages would be identify the pseudoexfoliation pupil and associated comorbidities, differentiate the rigid from elastic pupil. It's not the size of the pupil, it's the elasticity that matters. Remember that. Lower your threshold for using iris hooks or pupil expanders. Please sacrifice your ego for some time. IFIS is associated with alpha blockers, hypertension, and many systemic diseases. So you really don't have a foolproof history. Iris prolapse in IFIS depends on severity of IFIS and not on the pupil device. And always have iris hooks and pupil expansion devices in the operation theater. That's a very poor excuse. If you don't have it, it's in fact very embarrassing. I would encourage you to look up this particular article, which I wrote for eophtha.com, phacoemulsification in small people. Thank you very much for the kind attention.
Thank you, Dr. Suven, for a very elaborate talk on small pupil management. Of course, I shouldn't have added that pseudo exfoliation along his talk because he couldn't have dealt with both of it. Maybe we could just discuss 1 or 2 points related to pseudo exfoliation. I'm sure it goes without saying that we, of course, now all of us do SPM for all our, majority of us do SPM for all our category of cataract evaluation, but SPM is absolutely mandated in a pseudo exfoliation. Would we like to place a CTR in routinely in our pseudo exfoliative syndrome kind of settings? That is one question I wanted to ask. The second question is keeping in view that you see a patient with a little late IOL bag dislocation, but still very much in the center. Would you observe these eyes, or would you do a iris fixation, or would you remove the IOL bag complex and place an IOL?
Okay, my answer.
I want the expert panel to answer this.
Yeah, fine, thank you.
Sri Ganesh, Ramurthy.
Yeah, I think cases of pseudo exfoliation, not all of them dislocate. So if there is no phacodonosis, if there's just pseudo exfoliation, I routinely do not use a CTR. But what I like to do is I like to make a larger rhexis, a minimum rhexis size of 5.5 millimeter, because many of this over a period of time go in for capsular phimosis. And if there is any zonulopathy as such with phacodonosis, then I would prefer to use a CTR. And sometimes now, of course, my thinking is it's better to put a 3-piece lens, because I've seen a lot of these coming back after 10 years or so with dislocation of the complete bag, CTR, IOL complex. And then you have to remove them and do a refixation. If you put a 3-piece lens, then probably you can do a technique like M&A, because you can refix the same three-piece lens either with a glued IOL technique or a M&A technique. And now the thinking is probably it is better to put it in the sulcus, the three-piece lens in the sulcus, and do a capture of the capsulorhexis so that the late dislocations are not there. So this is the recent thoughts in pseudo exfoliation. Excellent presentation, Suven, and congratulations on your ring. I've also been using it. A few of the points I would like to make while using rings is that if you have a small pupil, especially a rigid pupil, then don't try to force the device and try to expand it with the device, because I have seen cases of zonular dehiscence when you're pushing this device in one direction and the pupil is not expanding. And so the stretch on the root of the iris is much more, and you can end up with a zonular dehiscence. I prefer, especially in a rigid pupil where you can actually see fibrosis, if you're not able to remove the fibrous membrane, sometimes you're not able to do it, then you do microsphincterotomies, because if you try to stretch this, you can get irregular tears. So it's better to do microsphincterotomies with a fine scissor and then stretch it. This will kind of give a more controlled kind of a opening rather than irregular tears. And then you can use the device, because most of these devices, especially if they are thin like Suven's device, they are more of retainers. So once the pupil is dilated, it retains it and keeps it in place rather than pupil expanders. I would call them retainers. The Maligan ring is more thicker and stronger, so it can push against the iris and try to expand it a little. But especially when you're using Suven's device, probably if it's a rigid pupil, then I would stretch it before using the device. In a 3mm pupil, if I try to use it, then it's very uncomfortable. So that is one point. And the other thing is an IFIS, along with a pupillary expansion device, please use a good viscoelastic, because what happens is even if you put a pupil expansion device, then the periphery of the iris, you know, it kind of floats up and starts prolapsing through your side ports or your main incision. So if you use a good OVD like Helon 5, then it keeps the periphery of the iris low, and you can use a low flow rate, and then you can complete your phaco safely, because once the iris prolapses out through the side port, then it keeps on prolapsing, and then you have a lot of iris chafing there, depigmentation, and it looks pretty bad post-op.
Thank you very much, Dr. Sri Ganesh. Welcome, Dr. Jagdish Reddy. I noticed that you are on online now in our presentation. I'm going to be asking you questions in the next for the PCR management. Because of paucity of time, I'm moving on. So please be hooked on, because I'm definitely going to attack you next.
So
our next,
yeah, just the questions that they would ask postgraduates. What is the pseudo exfoliation material? How many of the pseudophakic cataracts with pseudo exfoliation will go into pseudophakic glaucoma? So, you know, these are the things that they may just ask in the theory, and it again comes as a short case only, it never comes as a long case.
I think only you can answer it, Namrata.
And what is the material which is there? You know, it's a fibrillar material which is there. So almost 30 to 40% may go into pseudophakic glaucoma. The answer for that is, you know, how many of them could go into pseudophakic glaucoma, and what is the material? It is the fibrillar material. These are the, you know, theory questions that they will just ask.
And also, what is true exfoliation versus pseudo exfoliation?
Pseudo exfoliation, and
what is glass blower's cataract? This is a common question which the examiners may ask you. What is true exfoliation and versus pseudo exfoliation?
Just one practical tip, if I might offer. You know, Suven showed so eloquently about injecting viscoelastic under the pupillary margin before introducing any pupillary expansion device, whether it's iris hooks or whether it's any device which expands the pupil. But please remember, as he showed very well, that very often these IFIS cases have a tendency towards that. In IFIS cases, over installation of viscoelastic creates problems. At the same time, overfilling the anterior chamber also creates problems. In these cases, especially if you inject under the pupillary margin, there might be a greater tendency for the iris to prolapse out. In these cases, so you have to, there has to be just the right amount, because whenever there is pupil iris prolapsing out, there is an immediate tendency for repositing and overfilling it. So it has to be avoided. The second point that need to be remembered, it is not the prolapse the iris which causes a problem, but it is the reposition of the iris which causes the problem. So please do not reposit the iris through the same incision If in case it's prolapsing through the main port, go with the iris spatula through the side port and gently reposit it, and just inject a right amount of blob of viscoelastic to keep it down. Overfilling it is always counterproductive. Again, as was mentioned, right through the procedure, use slow parameters, low parameters, so that there's not too much turbulence and the effect of pushing the iris out of the various incisions that you make. Incisions you make have to be a little longer and more corneal, so that there's less tendency for the iris to collapse.
Thank you.